People hear that low carb makes 10 pounds disappear fast, and the internet treats that like proof of fat loss. What is the first thing you want them to separate?
The clean split is fat mass versus glycogen in water. Carbohydrate is stored partly as glycogen in liver and muscle, and glycogen carries water with it. When carbs fall sharply, insulin and glycogen storage usually fall, kidneys excrete more sodium and water, and the scale can move quickly before body fat has had time to change much. That does not make the diet fake. It means week one success should not be overinterpreted.
So if calories are matched, does keto still beat a higher carb diet, or is the advantage mostly that people naturally eat less?
In the recent Matched Energy Ketogenic review, the average extra loss was about 1.49 kilograms compared with higher carbohydrate diets. That is real enough to measure, but not the marketing version where insulin physics cancels energy balance. The authors also rated certainty low because there were few participants, mostly short-term trials, and imperfect knowledge of what people actually ate. Where low carb can feel powerful is appetite and food boundaries. If someone removes sweet drinks, desserts, refined grains, and snack foods, they may cut a lot of energy without counting. Protein and minimally processed foods can improve fullness. But that is different from saying butter and bacon are metabolically free. The useful version is less refined carbohydrate, enough protein, high-fiber plants, and unsaturated fats when possible.
If a person has type 2 diabetes and cuts carbs hard, is that a do-it-yourself experiment, or does medication change make it medically different?
Yes, diabetes makes it a medical intervention. Carbohydrate is the macronutrient that most directly becomes post-meal glucose. Reduce it, and post-meal glucose excursions often shrink. Weight loss also improves liver and muscle insulin sensitivity. In the very low-calorie diabetes trial, remission depended not just on diet composition, but on diabetes duration, baseline fasting glucose, and preserved C-peptide, which is a clue that the pancreas still had insulin-producing capacity. That trial is also a reminder not to oversimplify. Participants used a 600 to 800 calorie formula diet for 3 months with anti-diabetic medication discontinued in the study setting. Overall remission was reported in 72%, but it was 82% with shorter diabetes duration and 50% with longer duration. That is impressive, but it is not the same as casually swapping toast for eggs.
People also say low carb fixes triglycerides but can raise LDL. Is that cherry picking, or is the mixed lipid pattern actually what trials show?
That mixed pattern is exactly why blanket claims fail. A large 2025 meta-analysis of carbohydrate-restricted diets found lower triglycerides, slightly lower blood pressure, lower inflammatory markers, and higher HDL. But LDL and total cholesterol rose modestly. Ketogenic diets tended to produce greater weight loss and greater LDL increases, while moderate carb versions looked more balanced. So the food pattern and the lab response both matter.
Does low carb mean every carbohydrate is the enemy? Or should we distinguish soda and white bread from beans, vegetables, and higher fiber foods?
We should be explicit about boundaries. Pregnancy, lactation, active or past eating disorders, kidney disease, and unexplained high LDL responses are not casual low-carb territory. The lactation review found only case reports and series, but many involve hospitalization with vomiting, weakness, nausea, abdominal pain, malaise, or fatigue consistent with lactational ketoacidosis risk. That is enough to say weight loss ketosis, while breastfeeding needs medical caution. For children and adolescents with obesity, short-term studies show weight and metabolic marker improvements, including lower triglycerides and insulin. But the pediatric review also found heterogeneous methods and limited control trials. In plain English, this is not a family challenge from social media. If a youth needs obesity treatment, the plan should protect growth, micronutrients, relationship with food, and mental health while addressing cardiometabolic risk.
Even if the biology makes sense, how do you judge whether someone can live with it? Strict diets can become socially loud fast, right?
Exactly. A diet that works only in isolation usually stops working. The qualitative study of dietetic students described loss of control over choices, unexpected restriction effects, and social visibility even in motivated people receiving prepared meals. So I would design low carb as a repeatable menu, not a purity contest. Breakfast you like, restaurant options, fiber targets, protein adequacy, and plan flexibility.
If someone tries it responsibly, what should they measure so they do not confuse feeling disciplined with getting healthier?
I would run it like a reversible experiment. After 8 to 12 weeks, ask, did weight or waist improve beyond the water loss phase? Did glucose or triglycerides improve? Did LDL stay acceptable? Did the person feel able to eat this way? And did food quality improve rather than collapse into processed low-carb substitutes? If yes, it may be a useful pattern. If not, a Mediterranean, DASH style, moderate carb, or calorie-focused approach may fit better.